Hello, on behalf of the RSNA, thank you for joining us today. RSNA also thanks Hyland Healthcare for sponsoring today's webinar. My name is Dr. Richard Sharpe, and I will moderate today's panel. As you work to address COVID-19, I wanted to let you know that this webinar is one of the many ways RSNA is trying to reach the radiology community by providing education and resources on COVID-19. You can find these resources on the COVID-19 section of RSNA's website, which is updated weekly and sometimes daily. A link to this page is provided in the resources panel. With us today, we have Dr. Joseph Cavallo, Dr. Stamatia Destounis, Bill Greco, and Saduf Ali-Drakesmith. Before we formally introduce the speakers, there are a few things to let you know. Please use the question panel to submit your questions during the webinar. This webinar is being recorded and will be posted on RSNA's YouTube page within about 1 business day after this event. Now I would like to introduce Dr. Joseph Cavallo. Dr. Cavallo is an assistant professor and medical director at Yale New Haven Hospital. He is a recent graduate of the Yale Healthcare Leadership Fellowship and specializes in emergency and trauma radiology. Welcome, Dr. Cavallo.
Thank you, Dr. Sharpe. Good afternoon, everyone. Thank you to the RSNA for helping put this together and hosting it. Thank you to Dr. Sharpe for moderating, and to our panelists for their insights. I'm looking forward to our discussion. So I'm going to start today with a brief overview of the past 4 months, just how has the pandemic evolved and what's its current course. And then we're going to get into the specific drivers of both the decline and subsequent recovery in imaging volumes that we have observed. Then we'll move on to discuss some of the ongoing concerns around reimbursement and revenue and how management should be responding to the crisis moving forward. So when we started trying to think about how the pandemic was going to affect radiology back in March, cases were around 10,000 per day in the United States, but they were rising quickly. We published our paper in mid-April, which coincided almost exactly with the original peak in national cases. And starting towards late April, there was a slow but steady decline followed over the next 2 months. And as we speak today, the country is once again entering some uncharted territory. While many had hoped to have this behind us by now, that is unfortunately not the reality. And the United States is currently experiencing one of the worst outbreaks in the developed world. So here we have a graph just breaking down the different regions of the United States. And we said from the beginning that the evolution of the national picture has been and will always be a fluid story of asynchronous regional outbreaks. In March and April, you can see that cases were primarily driven by severe outbreaks in the Northeast, with New York City being the epicenter. And what we've seen over the past 6 weeks is that as the early regions have nearly reached total recovery, the South and West are now the epicenter of a new outbreak. Bearing this in mind, it's going to be important for those radiology practices in the South and West, many of whom took drastic efforts that appeared like an overreaction at the time, to learn from the experiences of the Northeast as they handle the summer and coming fall months. So as the crisis began accelerating in late March, we were looking at early imaging declines both in our institution and throughout the country. And we were using Europe's experience to try and look a few weeks ahead in terms of what is this going to look like as it shakes out. At that time, we predicted that practices could see anywhere from a 50 to 70% reduction in volume, and we postulated that it could last anywhere from 3 to 4 months. This has turned out to be pretty close to real-world observations, and we'll get into some examples in just a bit. We have here the 3 main drivers that were responsible for the decline. It was March 17th when the ACR endorsed guidance from the CDC to reschedule non-urgent outpatient visits. This had its greatest impact on screening services such as mammography and lung cancer, but it also affected almost every other modality, at least in part. As lockdowns were issued at state level and eventually a national pause recommendation came in April, we saw a significant drop in both physical and economic activity. Decreased activity levels resulted in lower transmission of COVID, but also other communicable diseases such as the flu. The overall diminished physical activity and travel led to decreased instances of trauma. Both of these combined to result in significantly lower imaging needs. And in terms of resource preservation, you're probably all well aware now that there were nationwide PPE shortages in March and April. This was obviously exacerbated by a worldwide strain on the supply of these materials, as almost every other country was facing this at once at that point. So efforts to preserve PPE necessitated the halting of many elective procedures, and this had spillover effects into interventional radiology. So let's try and take a quantitative look at how imaging volumes were affected in different practice settings. First up here, we have an example of an academic medical center. This data is from the tri-state area. This particular hospital system saw its peak census of COVID patients during the third week in April. In terms of a timeline for some key events around in this area, it was during the second week of March that this institution instituted screening for outpatient exams. By the third week in March, outpatient volume had already decreased by anywhere from 35 to 80%, and the 80% decline was in mammography. This coincided with ACR's recommendation to defer non-urgent imaging, and by the last week in March, they had closed multiple outpatient facilities, which were completely shut down for reasons of both patient safety and overall lack of demand for imaging. You can see from the graph that imaging volumes continued to drop precipitously throughout April. Emergency room and inpatient volume quickly fell and followed the outpatient decline. Overall volumes reached a nadir of approximately 50% off of baseline. If we adjust annually and assume that we do not have another lockdown type scenario between now and January, we're looking at a revenue of approximately revenue drop of 13%. For a setting like this. And this does not capture reductions in research-related funding that are also likely to have a significant effect on academic institutions. So I just want to point out the exceptional nature of a situation. This was different than all the other prior recessions we have faced. In general, economic recessions usually result in decreased healthcare expenditures, which ultimately translate to reduced revenues for medical service providers like radiologists. But the healthcare industry had never experienced a demand-side economic shock like this that was simultaneously exacerbated by the need to restrict its own supply of services. So this was a truly unique experience for radiology and many other industries in medicine. And now having seen the academic side, let's take a look at a small private practice in Michigan. This data is actually from a recent RSNA special report that was co-authored by our moderator, Dr. Sharpe. I encourage all of you to read it if you have not yet done so. It takes an in-depth look at the pandemic's effect with special attention to private practice radiology. For context, the group demonstrated in this graph employs four full-time radiologists and has a normal yearly imaging volume of approximately 55,000 exams per year. The drop in volume here was similarly precipitous. It reached a nadir of closer to 65% off baseline compared with the 50% from the large academic center. While these are only two anecdotes, we would expect to see this pattern of outpatient-focused private practice experiencing a greater dip in imaging volume to be fairly consistent across the country. In general, private practices have a lower percentage of inpatient and emergency room volumes as part of their portfolio. And while outpatient-heavy imaging volumes are traditionally very lucrative, such practices quickly found themselves among the most disadvantaged groups during the pandemic. And then on this slide, we're just trying to show in a very non-scientific fashion that the two examples we just reviewed are not outliers. They're in line with more aggregate data. This graph is this data is from a private radiology diagnostics company called AIDoc. Some of you may be familiar with them. This shows the combined CT computed tomography imaging volume of their clients in the United States and the European Union. The United States is highlighted in red here, and the European Union is in green. The solid lines are demonstrating the trend in CT imaging volumes over the weeks of the pandemic. The graph starts with a pre-pandemic baseline of in February and runs through the end of June. Overlaid overlaid on this graph with the dotted lines are the corresponding daily case totals for each respective region. So as you can see, there were similar percentage drops in volume observed across the board. Europe's nadir came slightly earlier than the United States, and this was not unexpected since they were experiencing the outbreak on a slightly advanced timeline. And in the United States specifically, the low point came during the 7th week of the outbreak, corresponding to the final week in March, and volumes for CT at that point were down 40% off of baseline. You'll also notice that as of the end of June, the United States had almost recovered. They're at about 97% of their baseline, while the EU had made a complete recovery to pre-pandemic averages. This difference could be attributed to the very different course in terms of disease transmission that the two regions are facing. So the speed and degree of imaging volume recovery is multifactorial. In both of our examples, we observed that imaging volumes did not return to 100% of baseline. It also generally took 6 to 8 weeks after the peak in daily COVID cases to recover to a new baseline of somewhere between 85 and 95%. One of the factors that's going to be driving this is patient insurance mix. Between February and May of this year, 5.4 million people lost their health insurance. With so many people losing insurance, care can easily be deferred or in some cases completely skipped. While some of the job and insurance losses are being reversed, many of the losses will be permanent or at least prolonged. After a steady 3-month decline in unemployment claims, the numbers that were released this morning demonstrated the first bump in weekly claims in almost 3 months, with 1.4 million workers filing new unemployment claims. Other data from Yelp that was just released demonstrated that of over 130,000 small businesses that they had been tracking, which temporarily closed since March, 55% of those have converted to permanent closures. So of those people that do regain insurance, some of them will shift to lesser generous plans such as Medicaid, and this will have important reimbursement implications. And another point about long-term reimbursement rates is the potential impact on state budgets that this pandemic has had. So the pandemic response costs were massive, especially for some of the hardest hit areas like New York City, which as an example estimates a net cost of $5 to $10 billion. Federal relief to the states has not exactly lined up with the severity of responses. New York State's per capita relief funding was in the middle of the pack compared to all other states, despite having by far the worst outbreak in the country. Many practices have already experienced significant reductions in revenue. You're all very familiar with that by now, but the pandemic is far from over, and all practices and groups will be subject to potential for continued disturbances of normal financial operations. Obviously, as the shutdowns were lifted and phased reopenings moved forward, more and more exams could be performed, things got closer to normal. But as we showed earlier, regions continue to experience ongoing or recurrent outbreaks of varying severity. And there is always the possibility of a partial or complete shutdown once again being instituted by the states. This is of particular interest to some states in the South and West, like Texas, California, and Florida. But at this point, we have 16 states who are seeing over 1,000 new cases diagnosed per day. So it's definitely not an isolated incident. In the case mix of practices is going to remain important. As I alluded to earlier, while imaging reductions will affect all radiology practices, outpatient-focused radiology groups will remain the most at risk. Elective imaging will likely be the first category to see reductions if and when volumes do decrease again. And elective imaging is also the most susceptible to changes in patient sentiment. Anything perceived non-urgent could be deferred if there's concern about safety. So while most significant for private groups, this still has important implications for all radiology practice settings. As most of you know, outpatient imaging in general has the most favorable revenue profile regardless of your practice composition. Outpatients are more likely to be commercially insured and their disease acuity is generally lower. In terms of relief funds, we've seen a disparate impact of recovery funds from the CARES Act. in general, funding disproportionately went to institutions that ended up having more cash reserves or were more financially healthy to begin with. This is for a few reasons. The legislation was passed rather quickly, and they passed up any opportunity to try and develop new formulas for calculating need. They ended up just going with reimbursement based on a percentage of your 2019 Medicare collections. So it was 6.2% of 2019 Medicare collections. And this obviously was preferentially advantageous to groups that were already doing well. Some institutions that were already in a tough financial situation, many of which are safety net hospitals serving rural or underrepresented communities, are in continued distress and will struggle to remain solvent. And this is of particular concern because COVID is having a disproportionate effect on these populations. As an example of this disparate relief, a private academic hospital system in New York City received over twice as much relief funding as a city hospital system in the same region, despite the fact that the city hospital oversees 40% more inpatient beds. So let's transition into management responses to the crisis. Teleradiology has seen a big boom from this epidemic. Radiology is fortunate in that it is widely adaptable to remote imaging. When the pandemic hit, there was a rush to transition much of the workforce to remote operations. I'm sure we will speak more about this on the panel, but there's a lot for practices to think about anytime you undergo a quick expansion of this magnitude. And what is often achieved over months in a normal setting was being accelerated to completion in a few weeks. So as you can expect, there were significant supply strains and delays in hardware acquisition, which were a problem that some groups had to grapple with. Increased share of remote imaging, and in some cases, additional applications to support it, made safety and security a big priority. And all this expansion of software likely required expansion of IT hours or IT staff to support it. In addition to these investments, anytime you change a workflow so significantly, so quickly, you may run into functional deficiencies, that create a opportunity for workflow optimization software. One interesting thing to consider is what's the long-term effect of this rapid expansion to telework going to have on the field, and are we looking at a new normal? So there have been significant workflow changes, as well as short and long-term financial implications for radiologists. We have seen some staffing reductions. It's included early retirements, elimination of locums contracts, mandatory reductions in shifts, mandatory vacations, and furloughs. That being said, staffing reductions are certainly not uniform. As mentioned earlier, many settings are running expanded hours or requiring more staff to handle pre-pandemic volumes in a post-pandemic socially distanced fashion. And depending on the mix of staffing changes, this could be either a net cost driver or a net cost saving process for practices. In terms of investments, many practices have had to modify, postpone, or even cancel physical or IT infrastructure investments. Expansions in terms of physical space or additional imaging equipment that appeared lucrative just a few months ago may no longer have a well-defined return on investment. And the pandemic is having a significant impact on how medicine is practiced in general. This will have important implications for how radiology serves the field going forward. Anecdotally, as many as 80% of clinician visits are now being done using telemedicine at some institutions, and the initial feedback from patients is generally positive. So we're likely looking at a new normal and how the majority of outpatient care is administered. Maybe not to this degree, but it will definitely be more telemedicine focused than it was before the pandemic. So, large ambulatory centers that were being planned to co-locate outpatient clinics with imaging centers, they're now of questionable utility. The need for waiting rooms has been completely eliminated by many practices, and clinic space is now an underused utility, with most visits being done through telemedicine. On the flip side of these changes, there may be opportunities for practices to reconfigure existing spaces to create room for imaging equipment in locations that previously did not have the physical capacity for more machines. So how can you stay on top of what is happening? Most hospital systems have task forces or working groups based around infectious disease that are actively monitoring regional data regarding the virus. But how should private practices be monitoring the pandemic? At this point, the majority, if not all states, have widely available public data, with many giving detail down to the county level. And there are three main metrics that can give you a good idea of where your region is in terms of severity. I'm not trying to make anybody an epidemiologist here, but you can get a pretty good grasp of what your situation is just by looking at these three metrics. The first is positivity rate. We've had rapidly expanded testing capabilities throughout the country after a slow start, which has really helped us get a better handle on exactly what we're looking at. In regions where the positivity rate is climbing alongside the number of tests administered, this is a worrying trend for increased disease transmission. And this, along with raw case totals, is going to be your first indication that disease levels are increasing. Hospitalizations are the next metric to pay attention to. There's an approximately 2-week lag between when new cases are found and when patients will begin to end up in the hospital. This has decreased a bit since the beginning of the pandemic, because we're testing more of the asymptomatic population. But speaking from personal experience in the ED, it was almost like clockwork reading the histories of patients that were coming in with COVID in late March and early April. 7 to 10 days after symptom onset, that's when they were showing up with trouble breathing. And then finally, we have deaths. Deaths are the most lagging indicator that we have. And we don't expect to see death totals increase for 3 to 4 weeks from when cases start to rise. If the death totals in your area have peaked, you're likely on the downside of the regional outbreak, but do bear in mind that the decline in cases is always slower on the back end than the acceleration of cases was prior to the peak. So priorities for practices during recovery. There's a lot of financial aid available to radiology groups. The full scope of the past legislation is beyond this discussion, but the ACR and RSNA have well-developed and detailed summaries of the many funding and relief mechanisms that can help groups from the perspective of being both a healthcare organization and, in a more general, a small business. Health and wellness of staff should be at the forefront of changes to practices and planning over the next 6 to 12 months. Not only do we need our staff to feel safe, but we also have to acknowledge the significant stress that many of them are going to be under. The possibility of ongoing school closures and disruptions to daycare are just two of the potential complications for our employees and their work-life balance moving forward. And practices are going to have to stay lean. We're all anxiously monitoring, for more effective treatments and an effective vaccine. But until that time, the situation remains fluid. Larger groups and those that are part of a hospital system will likely have a lot more flexibility to navigate the uncertainty. But smaller private practices may be forced to make significant changes. Hospital contracts, partnerships, or even outright sale could become attractive if not necessary. And then, in terms of planning ahead, I think states are going to be likely hesitant to reinstitute full lockdowns. There's quite a bit of fatigue among both the public and our policymakers. And, we're already seeing states that have pretty high levels of disease spread that are close to or on par with what we saw in April, but we're not seeing the same degree of lockdowns. So, despite this apprehension for restrictive maneuvers, they could again be relevant if specific regional hospital systems start to approach capacity. And then, as I touched on briefly in the last slide, safety is going to be at the forefront of all planning, both for their own patients and their staff. This can include some combination of monitoring the local case levels and positive testing rates, as we just discussed. It can include measures such as testing of asymptomatic staff and screening or testing of patients prior to appointments. As I alluded to before, our practice has almost completely removed waiting rooms from the patient flow. All pre-registration is done online. There's no need for the exchange of papers, pens, or any other materials between staff and patients. And when patients arrive to our site, they go directly from their car or the entrance into the imaging room. Some other measures has been the complete elimination of oral contrast unless it is specifically indicated and of paramount importance. And a lot of MRI protocols have also been shortened. And a lot of these changes are likely here to stay, and that's probably a good thing for some of the more efficient workflow processes that we've developed. One of the tools is universal screening protocols for appointments. As I mentioned, patients that are positive to screening questions based on symptoms or travel can be directed to designated hot sites for their imaging needs, if your practice is large enough to be able to accommodate something like that. And the necessity of all these measures is likely going to be dependent on the prevalence of disease in your specific community. Connecticut was in the thick of this back in April and May, and as we progressed out of it, our system put together a very ambitious and large-scale asymptomatic testing program, tested over 1,000 staff, but by that point, the community spread had gotten so low and infection protection measures were so well established that the positive rate was under 0.2%. And another big part of this safety piece is communication. The situation continues to be rapidly changing. Best practices and policies can change sometimes as often as daily, and establishing a consistent and effective means of communication with both your staff and patients is crucial. Speaking to my own experience again, the initial days of the outbreak were quite hectic. We were getting a dozen emails from different sources throughout the hospital. It was totally unsustainable. It was overwhelming. There was lots of repetition. But hospital leadership, thankfully, was very quick to recognize that as an issue, and they've established a consolidated daily briefing. It's now probably a weekly briefing as things have calmed down, but that was super helpful. And we'll need realistic expectations moving forward, and ability to spot and manage potential downturns as they arise. As I discussed, volumes may decrease in addition to or independent of local policy action. And this dichotomy comes from patient fear. We've seen that this can be pretty harmful. There's been some literature about the serious consequences from patient-motivated delays in care, delayed cancer diagnosis, missed cardiac events, poor stroke outcomes. And the evidence supporting this point is seen largely in a lot of the mobility data that's been made available by both public and private sources. When you look at this data, it consistently demonstrates that physical and economic activity have an early and inverse correlation with the level of regional disease spread. And then here's just a few examples of some of the recovery resources that are available. There's a wealth of education materials and guidance for radiologists and our patients, thanks to the efforts of the RSNA, the ACR, and other specialty organizations. I encourage everyone to engage with their societal organizations and take advantage of these multiple resources. Here's an example of a patient graphic produced by the ACR for messaging about new safety protocols and the overall safety of getting imaging done. And as an additional example, the RSNA COVID Task Force has produced many materials, including this guidance here on preparedness for elective imaging guidelines, decreasing patient and employee exposure, and additional COVID-related education. So links to these and other resources will be available in the references. Thank you for your attention, and I look forward to your questions.
Wonderful. Thank you, Dr. Cavallo. Now joining us for a panel discussion is Dr. Stamatia Destounis, and from Hyland Healthcare, Saduf, Ali-Drakesmith, and Bill Greco. Dr. Destounis is a radiologist at Elizabeth Wende Breast Care, a private practice with multiple outpatient offices covering a 200-mile radius, providing all breast imaging services around the Rochester, New York area. Dr. Destounis serves on many committees for the RSNA and is also on the RNE Foundation Board of Trustees. Saduf has a background spanning over 20 years in the imaging field, as well as technical knowledge in radiology, IT, and digital transformation solutions. Bill has extensive experience within the technology and healthcare environments, and strong technical expertise related to process improvement strategies that contribute to streamlined operations. We'll now turn over to the panel discussion, and we'd like to remind everyone to submit questions via the online panel, looking at the question section. So this question will go to all of the panelists, and we'll start with Saduf, and then move to Bill, Dr. Destounis, and Dr. Cavallo. We'll ask everyone to take less than a minute or so. From your experience during the height of the surge, what demands did you see put on your colleagues and peers?
So from my perspective, I think the biggest demand was on our time. I'm speaking from a European perspective. There was a huge call to ex-colleagues, to retirees, to come back to the front line. But then after that, I think the second biggest demand that we saw was the ability to still function in some sort of remote fashion. So from a radiology perspective, we were trying to see, could we improve PACS access from home? Could we improve radiological imaging access for anybody who needed it? If we'd furloughed radiologists, could we have them still able to work effectively remotely?
Wonderful, thank you. And we'll go to Bill.
Thank you. I'm going to address the reprioritization of patient care. The business of radiology involved 4 key pieces: an order, images, the report, and the bill. And productivity is always equated to profitability. So the radiology practices that had high productivity always were the most profitable. And once the pandemic hit hard in areas like New York, New Jersey, and now in Florida and Texas, the dynamics of radiology healthcare shifted. Outpatient elective procedures stopped, inpatient volume increased exponentially. Granted, radiology still needs to be productive, but the refocused emphasis on patient care has always increased. So as a registered technologist and certified nuclear medicine technologist for the past 43 years, I cannot be more proud to read of the efforts of the frontline workers, the technologists, the radiologists, transporters, and administrative staff who worked under perilous conditions day in and day out. They are the ones who have helped refocus healthcare and radiology to the best perspective of prioritizing and providing excellent patient care.
Excellent. Dr. Destounis?
Yes. So for us and my peers, we're at an outpatient breast imaging center. So for us, it was performing screening mammography studies and diagnostic mammography examinations. So we had to stop. We basically had to shut down and recreate ourselves and create new workflows that were safe for our patients and our staff, including obtaining PPE and restructuring our entire scheduling system. So we had to contact all our patients and cancel them as we closed, and then had to find a way to reopen with this new structure. So it was pretty stressful because of the rapidity of how this happened. Very quickly, we had to close and then consider how to reopen as quickly as possible and as safely as possible to provide services for at least our diagnostic patients.
Excellent. And Dr. Cavallo?
Yeah, I'll speak to the emergency setting. For us, a lot of the initial concerns were based around changing our workflows to manage infection prevention and protect our staff, specifically the technologists. Being one of the first areas to see a really significant outbreak, there was a lot of questions, especially given the lack of testing that was available and how we could prioritize and protect the safety of both non-COVID patients in the ER and our staff.
Excellent. We'll proceed down to the next question. What do you think is the trajectory of the pandemic? Do you anticipate that we could see nationwide impacts like we saw in March and April? And we'll direct that to Dr. Cavallo.
There's a lot of uncertainty in where things are going. The last month has been, we've seen a pretty substantial increase in cases, but looking at the last week of 7-day rolling average data, it looks like we may be hitting a plateau. Part of that is due to some of the worst states starting to get it under control, namely Texas, Florida, and even the southern part of California, although Northern California is still seeing an acceleration in cases. In terms of how this plays out, the next 3 to 4 weeks are already set. We'll probably see the death rate continue to increase for a little while. And we don't know if this plateau in cases is going to hold steady, if it's going to decline, or if it's going to start increasing again. We do know that we're not enforcing the same restrictions that we were seeing in April when the first wave was hitting its peak. So depending on how much we can suppress transmission before the fall, we could be looking at a difficult situation as we try to open schools and people are forced back indoors.
Very helpful, thank you. We'll turn to Dr. Destounis with a question. How can we better convey a message of safety to our patients? And at what point can we know that patient or staff safety may become an issue?
So I think the best way now is what we are doing, which is, recreating our workflow. So patients are coming in and you don't have many patients in your waiting rooms. You have social distancing. Everyone is wearing a mask that enters the building. For us in the outpatient setting, we have a no visitor policy. The patients are contacted and they can actually get checked in from outside in their car. And we also have given them the opportunity to get their results via texting or email. So we're keeping them safe by keeping very few people in the same room at the same time, cleaning the surfaces and letting the patients know, screening your staff and your patients and pre-screening everyone, before they come in. And that's how you're keeping staff and patients safe. I think obviously if there's more outbreaks that come in the fall, and I'm in the Northeast, and again, we have the severe outbreaks that we had initially in the New York area, and we're not able to obtain PPE or do the social distancing and the cleansing that we're doing of every surface currently, and the way we're doing things. Obviously, if that's not safe, then we'll have to reconsider again. And for us in the outpatient setting, we may have to obviously curtail our services.
Excellent, thank you. And then we'll extend this question to everyone. We'll start with Saduf. What do you see as future challenges as a result of COVID-19, and how will this impact your work?
So I think the length of disruption for patients that are requiring healthcare, whether that be acute or elective, still remains unclear. And that's our biggest challenge. I see some forward-looking healthcare organizations starting to use this time to materially scale out their virtual health offerings in a way that's going to create competitive advantage for themselves. And I see a challenge in that we're going to be more demanding of our IT vendors to keep up with this. It's no longer going to be satisfactory to just have accessibility to solutions, but we're going to want that workflow. We're going to want everything that we have when we're on the front line or when we're in our healthcare organizations, but through this virtual offering. And I feel like we're going to have to become more adaptable and flexible. We've seen already that even, I think Dr. Cavallo showed a slide there where numbers still haven't gone back down to pre-COVID. So are we going to just see this new level of increased activity, or are we still going to see these peaks and troughs that we're going to have to suddenly adapt to again and either ramp up, whether that be from a resource perspective, whether that be from an IT perspective, whether that be from a PPE perspective, the challenge of having to live with this unknown coming in whatever wave it's going to come in.
Very helpful. We'll turn it over to Bill with the same question about what you see as future challenges as a result of COVID-19 and how it will impact your work.
The new normal that we are all working under will unfortunately continue for the near future. So organizations and healthcare providers have quickly recognized that remote support will need to continue. The ability to be innovative, flexible, and nimble in both approach and response will equate to continued success. Mastering the use of Zoom, WebEx, Teams, etc. will be mandatory. Personally, in the past 6 months, I've provided remote training for customers across the world in the US, Finland, the Netherlands, and the UK. While I am not garnering air miles or hotel points, I'm effectively providing the same training as I would have in person. Extraordinary adaptability and a consultative approach with customers will need to be the norm moving forward.
Excellent. Thank you. We'll go to Dr. Cavallo next. Again, what do you see as future challenges as a result of COVID-19, and how will it impact your work?
First I'll touch on the clinical aspect. I think this is here to stay. I don't see it going away. It's going to be a part of management and infection control and diagnosis moving forward for quite a while. And then one thing I'll bring up, at least in an academic setting, is the effect that this is having on resident education. With social distancing requiring lower numbers of people in the reading room at once, some residents have had their time on site diminished, and it's also much more difficult to give the same educational experience through a teleradiology or remote setting rather than sitting right next to one of your trainees.
Excellent, thank you. And Dr. Destounis, the same question. What do you see as future challenges as a result of COVID-19, and how will it impact your work?
So speaking again as a breast imager in this group, we are very much the patient's clinician. So short term, we're managing to get the patients through and take care of their needs, but we're used to communicating with our patients, holding their hand, frequently hugging them as you're giving them a bad diagnosis and you're saying something that's could be life-threatening to them. And this definitely has changed things for us with social distancing and the masks on. It really does. You need to be quite creative to be able to still show that empathy, through your eyes and still not, be near the patient. So it does provide challenges to be a very, very good communicator and continue to take care of patients as we've done in the past. And I think these challenges will be here to stay for quite a while. So I do think we have to be creative as to how to continue to show compassion to our patients. And specifically in a field like breast imaging, that we are very close to the patient.
Thank you. And now we're going to turn over to some question and answer based on the audience questions. So thank you for having submitted questions. The most highly ranked question related to artificial intelligence. And so I'd like to direct the question first to Saduf and then to Dr. Destounis. Specifically, do you feel that the pandemic will hurt or help the overall adoption of artificial intelligence in diagnostic imaging?
I don't think it will hurt or help. I think those health organizations that have a wealth of data that they're running AI algorithms on they might take stock, and they might change their adoption of AI. They might look to using AI to give them some greater resilience within their business for this disease going forward. But I think for right now, I think nobody felt comfortable enough to really leverage AI. They might be looking at it going forward, revalidating and revisiting their current AI models in light of COVID-19.
And Dr. Destounis?
I agree. I think it was a bit of a missed opportunity as AI came up in the last few years and then COVID hit. I think though there is opportunity here for the groups and organizations that have it. And there is a wealth of data, and especially taking patients that may be at higher risk or have a high breast density, let's say on a mammogram, there may be a way to utilize AI to assign the patients that may be at a significant risk if they avoid their mammogram and somehow target those people, given the fact that we closed, let's say, for several months or slowed down considerably to really make sure that we alert those patients, they should come back because of the genetics, the family history, the breast density, whatever AI can help us, define and that they're in a higher risk category. So there's opportunity there.
Excellent. And I'd like to now turn to Dr. Cavallo with another question from the audience. how has the volume impact varied between inpatient and outpatient imaging services?
Yeah, so outpatient took by far the biggest hit. Outpatient volumes, down as much as 80%, and many facilities were closed. Inpatient volumes slowed down, especially in the institutions where there was a significant strain on hospital resources, just because all elective surgeries stopped. Any sort of admission that could be avoided was avoided. So the normal census of non-COVID inpatients decreased pretty significantly in hospitals that were worried about capacity. And with that came a lower degree of inpatient imaging, specifically because there was relatively few indications for imaging patients once they were already diagnosed. X-rays were generally used to monitor any really significant clinical deteriorations. At Yale, we actually developed some, portable through the glass techniques to try and decrease the use of PPE. But, there was a lot of apprehension to image these patients for fear of, further spreading disease throughout the hospital. And that was there were patterns that were seen in both China early on and especially Italy, that the hospitals could become a node of transmission, and so that's where the relative decreases in inpatient volume came from.
Excellent, thank you. Another question from the audience relates to how private practitioners are coping with the pandemic, and we'll turn this over to Saduf.
So I think there was a couple of points in Dr. Cavallo's slides, but from my own perspective, I've seen here in the UK and across Europe especially, their elective and outpatient activities had to stop due to social distancing, due to infection control, prevention measures. So what we saw was they really came they rose, they came to the front, they helped out with our public sector health demands. So that was great from that perspective, but it did mean that a lot of private practitioners stopped their own practices. So a decrease and a loss of revenue for sure. But we also saw from a Hyland perspective, we saw that, and this is the same with even public sector organizations, projects stopped. Funding had to be diverted into tackling the crisis. So we saw future projects either cease or delay indefinitely. We saw other reductions in costs to try and save monies, especially in that private practice arena.
Excellent. And I'll turn it over to Dr. Destounis for her comments as well.
So I think, workflow completely changed at private institutions. We literally were closed for several weeks before we were able to reopen. And then when we did reopen, we started with a very, very low volume in order to be able to perform, the tasks that we needed to do and perform them safely. Our workflow completely changed. We created a dashboard so we could see where the patients were, so no one was in the waiting room. So we checked them in from their automobiles and created texting and processes to give them their results. We continue to offer the patients the same day results that they wanted. But we really monitored that there was no one, in the building at the same time and kept everything sanitary. So our volume really decreased considerably until we got a lot better and started designating patients to the X-ray rooms. Once we started scheduling patients to each individual mammo room, then our volume started to go back up again. There remains the concern about how we will get through the backlog of what we really kind of lost out in March, April, and May. And I think, that will spill into next year. But we have managed to make certain gains between computerizing our systems, improving our IT, and really all the staff working together to get as many patients safely as we can. But private practices overall are seeing quite, along with the decrease in volume, also the loss in reimbursement. So that will go on for quite a while, I presume.
Excellent. And Dr. Cavallo, I think you had some items about workflow, and particularly in mammography, and how you made changes similarly.
Sure. Yeah. Similar to what Dr. Destounis was saying, when it was restarted here, patients, which were normally seen once every 15 minutes, appointments were every 15 minutes, were pushed to every 30 minutes. As they got used to that workflow, I think the steady state they achieved was, a patient every 20 minutes. But similar to what's been said previously, a lot of efficiencies in the registration and insurance check-ins and the patient experience have been developed, and nobody likes sitting in a waiting room. So I don't see any reason for these changes not to be permanent, both for improving the overall efficiency of our throughput as much as we can, and improving the patient experience.
Excellent. Thank you. And I'd like to turn it over to Bill with a question. This is actually from RSNA, from the social media questions that have been submitted. Do you think there will be an increased need for radiologists and radiology professionals in the years ahead?
I do. I think as individuals have been furloughed or had workflow cuts, things of that sort, probably a number of individuals are just not going to return. So there's always going to be the need for quality and qualified individuals to replace them. So I think that need is really going to exist as we move forward in this new normal workflow.
Excellent. Thank you. Now a question for Doctors Cavallo and Destounis. Could you tell us a little bit about what you anticipate being potential impacts on the radiologist job market and talent retention that result from COVID pandemic? So we'll start with Dr. Cavallo.
Sure. This in prior recessions, namely in 2008, we saw a lot of radiologists defer retirement, which negatively impacted the job market for emerging radiologists. But we've seen sort of a V-shaped recovery in the stock market, at least to this point, despite some of the larger economic indicators lagging quite far behind. But so it remains to be seen if we'll see that effect on retirements and how that will affect the job market. But there's also people are less willing to take a job change or risk some uncertainty in the face of an economic recession. So we may see some job lock with people staying in their current opportunities.
And Dr. Destounis, if you have any insights on what you think the impact is on the radiologist job market and talent retention.
I think, because as we all have reassessed, our job descriptions currently, we're, like prior speaker said, we're doing remote team meetings, and we're teaching remotely, and we also are reading remotely now. I think there's definitely teleradiology is going to increase, and a lot of the younger radiologists have the benefit of being very tech savvy and IT savvy. So I think some of us older radiologists, as this continues to be very different, may consider, that maybe this is a little too much technology. So some people that were close to retirement age may think, hey, this may be the time, because this is getting a little bit challenging on multiple venues. So I do think there may be opportunity for newer radiologists here, and the job market may increase a little bit because this is a very kind of different environment. And very tech and very IT heavy at this point. I think that'll continue for a while.
Excellent. Thank you so much. And then another question for Dr. Destounis related to screening mammography. You mentioned that you closed down services for a number of weeks. Dr. Cavallo mentioned decreases in throughput, over 80%. in some types of screening settings, particularly mammography. And I was wondering if you could tell us a little bit about what you see as the significance of this trend, either relating to, the economics of radiology and also patient outcomes.
So, our concern is, what are we going to do for those patients that didn't come back? That we did cancel patients, we closed, we did not have PPE, we did not have waiting rooms. You can imagine very busy centers and chairs all very near each other. So we had to recreate our space, educate our staff, create cleansing methods, change our workflow. So all that took time. And so there is concern that some patients that they didn't come in, they're too nervous to come in because of anxiety, because of COVID, may skip their mammograms. And, the data shows that obviously we want to find cancer small. So there's concern that as women skip their imaging for their screening needs, that we're going to find later stage cancers down the line. So that's definitely a concern for screening mammography, because there is a lot of anxiety that we hear from patients, even now when they do come in, and as we try to squelch their fears and try to make them comfortable and get them through their exam. I think our volume was nothing for a while, so the bills still to come in, so they do come. So in private practice, you do have to remain viable. So that's going to be a concern if we do get hit by another peak. How will we be able to, continue to stay viable and take care of patients, and also continue to offer screening so these tumors are found small, because I do worry about what's going to happen down the line if women skip their mammograms for a few years.
Thank you, very helpful. And then one last question from the audience before we conclude, and that's related to student education and what is going to be the impact on the pipeline of future clinicians and radiology professionals that we see happening. In my own practices, I see some students not able to be with their teachers in quite the same way in the same location. I see lots of Zoom education meetings. I also see people who want to do research or get additional experiences, having the brakes put on those as a result of the pandemic. So, I wonder, Dr. Cavallo or Dr. Destounis, if you have any thoughts on the impact on education related to COVID.
Dr. Cavallo?
Sure. Yeah, I know. I touched on this briefly. It's definitely harder to work in resident education from a remote perspective. You're not looking at the same exact screen, and we've dealt with this being a practice that has multiple sites. It's always a little better experience to be in the same room as one another. From a lecture perspective, we've been doing, remotely televised lectures to our different sites for quite some time. So I don't really see much of an impact from that perspective. To me, it's more the in-person, face-to-face education. And as you touched upon, especially with medical students, because they don't have access to the PACS and the remote viewer, much harder for them to get a feel for what radiology is actually like, and is this a field they want to pursue going forward.
And then I will turn it over to Dr. Destounis if you have any additional thoughts.
Yeah, so we're a private center, but we do a lot of clinical research. And unfortunately, everything has been at a standstill. You can imagine that as you're trying to social distance the patients as they're coming through your doors, this is probably not an appropriate time to approach them about any clinical research study, because you are trying to expedite their visit. So some of our clinical research work has really suffered, and I kind of get a little concerned about the near future and what we will be able to do, with education and research as things are. But I'm hopeful that things do improve. The fellows and the residents also need interventional procedures, which that is also a challenge right now. So it is a challenging time for the hands-on.
Great, excellent. Well, thank you so much for the entire panel, for this discussion, for the to the RSNA staff for organizing this, for all the participants who logged in and who watch this in the future. I would like to thank everyone for sharing your expertise. I'd like to thank Hyland Healthcare for sponsoring today's webinar and sharing your expertise as well. I encourage you to continue the conversation on RSNA's new community site. where your radiology colleagues and RSNA leadership will comment and answer questions. Please see the chat and resources panel for the link to that site. Thank you so much.